Hello, my geniuses. Welcome to another embryological lecture series today. It is your great science tutor Lorenzo, and we're talking about breaking and dissecting the embryology and the development of all organs and tubes of the respiratory system. So, if you are new to my channel and you're a first timer joining our fellowship, make sure to subscribe for me. Always just subscribe and turn on your post notification button so that anytime I drop any video, you'll be the first to be notified. And if you want me to make any video for you or any topic that is science related, ranging from mathematics, physics, medical, any stuff, maybe anatomy, physiology, pharmacology, write it down in the comment section on the video that you want. Then when I go to it, I'll make that video for you. So now stay with me throughout the course of the video because I'll be dissecting all the whole tubes and all the embryology or the development of the respiratory system. So let us jump right into the video. So before we start talking about the formation of various components of the respiratory system, you have to start with knowing the formation of the lung bud of the respiratory diverticulum. So where do you see the respiratory diverticulum of the lung bud? Remember, in the primitive gut we'll talk about in the formation of the gut tube, which is a tube formed by the endoderm. We said that in the first part, which is the pharyngeal gut or the primitive pharynx, what happens? It begins from where? It begins from the oropharyngeal membrane, which develops to form the mouth, down to the respiratory diverticulum. So the respiratory diverticulum is present in the what? As an outgrowth at the ventral wall of the foregut. Don't forget, the respiratory diverticulum, also called the lung bud, is formed at an outgrowth of the what? Of the what? Foregut. So it has a communication. It's just like a pouch that has a communication with the what? With the foregut. But one thing you have to know, what causes the formation of the respiratory diverticulum or the lung bud? It is the presence of retinoic acid. So retinoic acid present in utero or during developmental process causes the upregulation of the transcription factor TBX4 gene. So TBX4 gene is upregulated when there's a presence of what? Retinoic acid, and when this signal is developed, you can form the lung bud. Because if it is not formed, you can't form the lung bud, which means the fetus will have an absence of the lungs, which sometimes they might die. So the presence of the lung bud, remember the lung bud has a communication with the foregut, but with the presence of two longitudinal ridges. The two longitudinal ridges is called the tracheoesophageal ridge. The tracheoesophageal ridge, during rapid proliferation, fuses to form the tracheoesophageal septum with the ventral wall forming what we call the primitive trachea, which forms the trachea, while the dorsal wall forms the what? Esophagus. So since we know this now, one thing you have to know here is that the endothelial lining all this respiratory organ or all this respiratory component is what simulated by the presence of the endodermal origin. So they are from the endodermal origin. So the endoderm helps in the lining of the component of the respiratory system, while the formation of the muscles, the connective tissues, the cartilages in the respiratory system is by the what? Is by the visceral mesoderm, which is the splanchnic layer of the lateral plate mesoderm. So we have talked about the formation of the lung bud or the respiratory diverticulum from the ventral wall of the foregut, and it is divided by the tracheoesophageal septum into a ventral and a dorsal area. So now we said that the respiratory diverticulum has a constant communication with the laryngeal orifice, which is a part of the which is the lower part of the primitive pharynx. So one thing you have to know that the endothelial lining of the larynx here is endodermal in origin, same with almost all of the respiratory content of the respiratory tract. Why we said that their connective tissues, muscles and cartilages are always from the mesenchyme of the visceral mesoderm or the splanchnic layer of the lateral plate mesoderm. Don't forget, their muscles, connective tissue and cartilages and other components are from where? The mesenchyme of the visceral mesoderm or the splanchnic layer of the lateral plate mesoderm. Don't forget. So since we have known this part, but for the larynx now, theirs is gotten from the mesenchyme of the fourth and the sixth pharyngeal arcs, which develops later by when it continues proliferating, develops into the cricoid, arytenoid and the thyroid cartilage, short form for CAT. So the fourth and sixth pharyngeal arcs proliferates further and forms the future cricoid cartilage at C6, the arytenoid and the thyroid that are very key components of the larynx. So here we should also know that the lumen of the larynx is usually a sagittal slit shape during formation, but now it is converted to a T-shaped. So the permanent shape of the larynx is usually a T-shape, but formerly it was a sagittal slit shape. So the next is the canalization. Naturally the lumen are very, they are not obliterated at first, they are very solid, like it forms a solid mass which is closed all to, but obliteration starts. Obliteration and recanalization of the lumen of the larynx occurs continually to form what we call a lateral pocket or a recess called the laryngeal ventricle. So the laryngeal ventricle with time also, with continuous proliferation, it forms 2 and 4 sword vocal cords. So the continuous proliferation from the laryngeal recess or the laryngeal ventricles from the 2 and 4 vocal cord or fold. So since you have stated it already that naturally the lumen are very unobliterated, they were not obliterated, they were temporarily occluded at first, but when the lumen opens up between the 6 to 8 week, when the lumens opens up very well, they form a laryngeal ventricle or recess. But the laryngeal recess or ventricle after continuous proliferation forms what we call the 2 and the 4 vocal cords. So another thing you will know that the musculature is formed from the mesenchyme of the 4th and the 6th pharyngeal arcs, and they are all innervated. All the laryngeal muscles derived from the 4th and 6th pharyngeal arcs are innervated by the vagus nerves. So don't forget the muscles around the 4th and 5th pharyngeal arcs. The mesenchyme of the 4th and 5th pharyngeal arc are innervated by the vagus nerve, which is the 10th cranial nerve. Why derivative of the 4th pharyngeal arcs are supplied by the superior laryngeal nerve, while derivative of the 6th pharyngeal arcs are innervated by what we call the recurrent laryngeal nerve. So don't forget, derivative of the 4th is supplied by the superior laryngeal nerve, while derivative of the 6th pharyngeal arcs are innervated by what, the recurrent laryngeal nerve. So don't forget, why all the musculature of the larynx derived from the 4th and 6th are innervated by what, the vagus nerve. Don't forget. So we have discussed how the larynx is formed due to the continuous communication of the lung bud or the respiratory diverticulum with the laryngeal orifice. So next we'll be talking about the formation of the trachea, the bronchi and the lungs itself. So all of them are gotten from the origin, which is the lung bud. So we are talking about the larynx to formation of the conversion of the sagittal slit shape to a T, which is the lumen recanalization of it. So now in formation of trachea, we know that trachea is a form in the ventral part of the tracheoesophageal septum. So the lung bud that forms the tracheoesophageal septum separation, which forms the trachea, also forms 2 lateral out pockets or 2 lateral bud called the primary bronchi bud, while the dorsal part forms the esophagus, which we have discussed in our previous video. So now the 2 lateral out pocket, which is the primary bronchi bud, subdivides in the 5th week into what, secondary bronchi buds, 3 for the right lungs, 2 for the left lungs. Because now, why is it the secondary bronchi buds are formed from the primary bronchi bud? Why? Because we have 3 lobes in the right lungs and 2 in the left lung later. So this occurs in the 5th week. In further development, the secondary bronchi bud, 3 for the right lungs, 2 for the left lung, continue proliferation and continue dividing, forming what, 10 in the right lungs and 8 in the left lungs with continued division. So this forms what we call the bronchi tree, which is seen in an adult lungs. So by the end of the 6 months, you will have seen 17 generations of what, subdivision. So the tracheobronchi tree will have divided up to like 17 times. So the bronchi tree now we assume its final shape. So in postnatal life, you have to see, like after the child has been given birth, 6 more of the division will appear and join the previous one that was formed in utero. So something you need to know that also the lungs begins to expand continuously around this bronchi division, this bronchi tree division. The lungs begins to surround it. The lung begin to surround it. Both the bronchi tree and the remaining part of the foregut, the lungs begin to expand around it at a space called the peritoneal canal. So at first the peritoneal canal is narrow. That is where the lungs expand into. So it is very, very narrow. So at this particular point, the pleuroperitoneal and pleuropericardial folds separate the space where the lungs is called the peritoneal canal. It separates these two folds separate this canal from the pleura and the peritoneal cavity, leaving the rest called the primitive pleural cavity. So don't forget, the lungs begin to expand at a space called the peritoneal canal. That is where the lungs start expanding in between at either side of the foregut, with the bronchi tree expanding inside. So when they expand in this space, what happens? The pleuroperitoneal and pleuropericardial folds separate this space or this canal where the lung is expanding from the previous pericardial and peritoneal cavity, leaving the rest called the primitive pleural cavity. So now we have formed the primitive pleural cavity. The pleural cavity is just a covering of the lungs, and the pleural cavity covers the lungs. The remaining space formed when the pericardia and the pleural cavity have separated themselves from the lungs. So the remaining place. So now the outside part of the lungs itself, the outside part of the lungs, the outer part of the lungs is lined by what we call the visceral pleura, which is derived from the visceral mesoderm. Why? From inside to outside, the somatic mesoderm covers the body wall of the pleural space, forming what we call the parietal pleura, which is derived from the somatic mesoderm. Don't forget. Now the outside, the main outside close to the lungs, is separated by what we call the visceral pleura, formed by the visceral mesoderm. Why the parietal pleura covers the visceral pleura from outside. This covers the other part of the body wall of the lungs. So the space between the parietal and the visceral pleura forms what we call the pleural cavity. Don't forget it. To make all this very well, we need a signal. There must be a relationship between the mesenchyme and the endothelial lining. The mesenchyme and the endothelial line, there must be a communication, and this communication stimulates an upregulation of a signal called the fibrotic growth factor. So the fibrotic growth factor present in this place allows for the expansion, the formation of the lungs, the trachea and other place, and finally expand the lungs to sit in the cordial lateral part. So because the lungs expand cordially and laterally to sit at the back, so that when we are looking at the bifurcation of the trachea, it will be opposite the T4 T5, which in time we call the sternal angle. So the next one we're talking about is the maturation of the lungs. We said that the lungs expand into what we call the peritoneal canal, which is usually narrow, but later it expands with time. In the 6th month also, what happened? We say that there is about 17 subdivision of generation of the bronchus, which later in postnatal life, what happens? 6 more is added. But here in the 7th month, the bronchi continues to divide with enormous blood supply. The blood supply within them continue to divide. But something you should know here, that the terminal bronchi divides into what we call the respiratory bronchi, because we said the primary bronchi divides into the secondary bronchi. The secondary bronchi continues divide into more and more, which ends in 10 for the right lungs and 8 for the left lung, which is the terminal bronchi. But now the terminal bronchi, now what happens? The terminal bronchi divides into a respiratory bronchi, which marks the origin for the pulmonary or respiratory unit of the respiratory tract. So what happened? This respiratory bronchi divides further into 3 to 6 alveolar ducts. The 3 to 6 alveolar ducts ends up later, after subdividing, they end up as the terminal sac called the primitive alveolar. So forming the primitive alveolar are surrounded by what we call the flattened alveolar cell. which make contact with the what, with the neighboring what, capillary system. But at the end of the 7 months, now the alveolar sac now gets matured, which is primitive. It gets matured while the capillary system also are surrounding them, so that the fetus in utero at least can have what, exchange of gases between oxygen and what, carbon dioxide, to enhance what, life. Don't forget it. So this happens, as I said, the respiratory bronchi divides into 3 to 6 what, alveolar ducts. The 3 to 6 alveolar ducts ends up to form the terminal sac called the primitive what, alveolar. The primitive alveolar surrounded by what, flattened alveolar cell, and the flattened alveolar cell has good contact with what, they have good contact with the neighboring capillaries, which at the end of the 7 months, what happens, the end of the 7 months, the matured alveolar sac now have a good connection with the underlying capillaries, which is guarantee good gaseous exchange for the growth and development of the fetus. So towards the last 2 months of delivery, before the baby come out, before the fetus is given birth to, what happens? Like I said, the matured alveolar sac now have a good connection with the capillary system. So now there can be exchange of gases between them. But you always know matured alveolar sacs are not present before birth. They are formed after birth. So what happened now? There are 2 specific cells formed in this in utero now in the last 2 months. You have the first one is called the type 1 alveolar cell, what you call the pneumocyte 1 cell, right? The second one is type 2 alveolar cell called the pneumocyte 2 cell. So these 2 cells are formed. The type 2 cells basically forms what we call a surfactant. The surfactant is a lipid rich fluid which helps to what, decrease surface tension between the air to blood, or blood to air what, interface. So what happens? The surfactant is used to reduce. Why the type 1 cells are also, they are thinner, they are what, flattened alveolar cells, which allows the entrance of the capillary, or good entrance of the capillary system into the alveolar sac. So they are very, very thin. So the type 1 alveolar cells, or we call them the pneumocytes, allows the good thin connection between the capillary system and the alveolar sac. So they are flattened epithelium. So this boundary between the type 1 alveolar and the capillary system forms what we call a blood-air barrier. Very, very important. Why the type 2 produce what we call a surfactant? The surfactant is a lipid rich fluid which decreases what we call surface tension between the what, blood-air what, interface. Don't forget it. And now in the later part, in the 2 weeks, usually the ending of gestation, which is at the 34 weeks, what happened? The lungs is filled with fluid. The fluid are rich in what? They are rich in chlorine, very well. They are rich in protein. They are rich in mucus from the what, the bronchi glands, and they are rich in what, surfactant, which is the type 2 alveolar epithelial cells. And this surfactant has increased what, phospholipid, and the phospholipid migrate into the alveolar what, the phospholipid enters into the what, amniotic fluid, and as it enter into the amniotic fluid, it migrates into the amniotic cavity, where it acts on what, macrophages. When it acts on macrophages, they become activated. Then being activated, the activation now what, travels through the what we call the chorion. So it travels through the chorion into the uterus, where it does what, where it stimulates what we call an immune range of system, an immune system, to secrete what, interleukin 1b. That interleukin 1b is necessary for upregulate the formation of prostaglandin, which is how the fetus promotes contraction and delivery, and also inducing labor. So like I said, that interleukin 1b is very, very important, because the presence of that interleukin 1b stimulates labor and childbirth. So before birth, what happened? There's also fetal breath movement. So the fetus in the womb also breathes, at least, even though not every time, but it breathes so as to aspirate the amniotic fluid inside the lungs. So that aspiration of the amniotic fluid inside the lungs, and also swallowing through the esophagus, is very, very important for the growth of and the nourishment of the GIT tract, and also it's also important for lung development, and also for conditioning of the respiratory muscle. So you need it for conditioning of the respiratory muscle and lung development. But after interleukin 1 upregulate prostaglandin and labor occurs and the child is giving birth to, what happens? Now the first breath the child takes, what happens? The aspirated amniotic fluid are reabsorbed in the blood and in the lymphatic system. So while some during the coughing action, some are expelled through the trachea, through the bronchus and the trachea. But with the exception of some surfactants, the surfactant layer, which is the phospholipid layer, remains there. They are very thinner. They remains in the lungs. So why? So that when the child first takes his first breath, what happens? There will be what high surface tension that will occur, so that there will not be a blood to what air interface issue when air is taken in. We don't want that. So you don't want the counterbalance between air and water in the lungs. So that's why the presence of the surfactant is still present there, because if the surfactant is not there, the lungs will what collapse, because there will be an issue between the air coming in and the water content in the lungs. So that is why the surfactant is there. So with time, now this continues that with the growth of the fetus, what happens? The alveolar sac continues to grow. But on one new thing you want to know, I bet there we only have up to maybe 1/6 of the alveolar sac, but most of the alveolar sac comes after at least 10 years of age of postnatal life. So don't forget that. So with this, when air is taken into the lungs, what happens? The lungs will expand, and what happens? There will be negative interpleural pressure. Also the pleural cavity will also be filled, which will cause air to go into the alveolar, okay, with the presence of the surfactants there to help to prevent water to air interface or issues. So this continues, and also due to the capillary present within the alveolar sac to allow for good gaseous exchange. So this continues to help in good respiration of the fetus. Don't forget all this stuff. It's very, very important. So we have talked about the maturation of the lungs, we have talked about the bronchus, we have talked about the broncho, we have talked about almost everything. So we go into the clinical correlation. What are the clinical effects of the development of the respiratory system? So the clinical correlation to the development of the respiratory system is just simple. When there is an absence of surfactant, it's so clear. I've said it that the absence of surfactant will cause collapsing of the lungs, because the surfactant is there to prevent blood to air interface or issues that will occur. Because when you take in air, the presence of the blood component there and the water component of the blood prevents the air from entering the blood and the content of the blood to enter into the lungs. So this can give a great issue, because sometimes when the surfactant is absent, what happens? There is a presence of high protein content. In absence of a surfactant, the surfactant layer produce protein, or what we call the laminar structure, or a hyaline membrane, called the hyaline membrane disease. You can call it a hyaline membrane disease. So in absence of surfactant, it's either you see a high amount of protein or hyaline component or a laminar component, which can suggest a hyaline membrane disease, and which can cause respiratory distress syndrome, and this causes at least 20% of death in infancy. Because when surfactant is not produced, anything that happens, the absence of air inside the lung can just collapse. So that's why preterm babies are treated with artificial surfactant, while their mother rather is infused with corticosteroid to allow surfactant production. So surfactant is very, very important. Even though you expect all components of the lungs that has entered, what happens? You need the phospholipid layer, which is the surfactant, which is present to reduce surface tension and allow for a good blood to air relationship. So another one is the ectopic lung bud. The ectopic lung bud are just additional lung bud that is formed separately from the normal respiratory system development. So when after a respiratory system form and there is a new lung bud that might form, which will form different respiratory systems, so you now have, instead of 2 lungs, you have more than 2 lungs. So we call it ectopic lung bud. So now don't forget that. So other abnormalities, you can have so many issues. They can be agenesis of 1 lungs, maybe you form 1 lungs, or the trachea instead of it to form the primary bronchi bud is closed, it form a blind end. That can also happen. You can also form what you call supranumerical lobus of the lungs, which is also, all these are just abnormalities that occurs in lung development. So I hope it all made sense. Have you understood the development of the lungs, starting from the lung bud down to the formation of the larynx, and this occurs due to the production of the rectanoic acid, causing the upregulation of the TBX4 gene, which causes the formation of the lung bud. And here we talk about the larynx. After the larynx, we talk about the trachea, the bronchi, and the lungs. Now we talk about the maturation of the lungs. Hope it all makes sense to you and you understand. So watch the video over and over again and ask your questions if you have any. So if you are just joining my channel, make sure to subscribe and turn on the post notification button so that anytime I drop any video, you'll be sure to be notified. So if you want me to make any video, also drop it down in the comment section. I promise to make the video for you. So have a nice day and continue studying, and also try to use your atlas and watch most of my videos. They are very, very helpful. Bye bye.